Thank you for joining us. I'd like to welcome everyone to the first installment of the Society of Thoracic Surgeons and the Society of Cardiovascular Anesthesiologists webinar series. Today's webinar is titled Across the Drapes, Multidisciplinary Management in Thoracic Aortic Surgery. Please note this webinar is being recorded and will be available on the STS and SCA websites and the STS YouTube channel. At this time, I'm pleased to introduce our moderators for this evening, Drs. Gina Lingana.
Thank you so much for that introduction. Welcome everyone to the STS SCA webinar, Across the Drapes, Multidisciplinary Management in Thoracic Aortic Surgery. As was mentioned, my name is Dr. Gina Lingana, and I'm from the Hospital of the University of Pennsylvania in Philadelphia. I am joined today by my co-moderators, Dr. Shubhashish Chatterjee from Baylor College of Medicine in Houston, and Dr. Rakesh Arora from University Hospitals in Cleveland. Dr. Arora will be fielding questions behind the scenes. So if you have a question you'd like our speakers to address, please put them in the Q&A and we will address them along the way. And now to introduce our speakers from the University of Toronto is Dr. Chatterjee.
Good evening. I'd like to introduce our colleagues from the University of Toronto. First, Dr. Marcus Salvatore, a cardiovascular anesthesiologist at the Toronto General Hospital, and Dr. Maral Uzonian, a cardiac surgeon and surgeon scientist at the Peter Munck Cardiac Center at Toronto General.
And from Northwestern University, we are pleased to have with us Dr. Charles Hogue, Chair of Anesthesiology, and Dr. Chris Malazri, Professor of Surgery and Surgical Director of the Comprehensive Aortic Center.
Now,
Thank you.
Let's begin with our case. So, for our panelists, we begin with the 77-year-old lady who presents with tearing chest pain to the emergency department. The initial evaluation for acute coronary syndrome is unremarkable. A CT scan is obtained, which demonstrates an acute DeBakey type 1 acute aortic dissection. The patient was oriented to time and place and neurologically intact. Blood pressure were in the hundreds over 60s. Heart rate was in the hundreds and tens. A CT surgeon was consulted. Now, for a brief reminder, a type 1 aortic dissection in the DeBakey classification involves the ascending and descending aorta. A type 2 and type 3 are listed respectively there. Next. This is the CT scan imaging, which demonstrates a classic type 1 aortic dissection. The ascending aorta is dilated and involved, and the descending component extends all the way down into the abdominal portion of the aorta. Next.
As we mentioned, we're coming to the operating room, so an intraoperative TEE was obtained. Here you can see a type 1 aortic dissection and a dilated ascending aorta. Here is that same image with color flow across the valve. You can see that there is some aortic regurgitation, and you can once again see that the dissection is demonstrated. Here is a view of the aortic arch, and you can see that there is a tear in the aortic arch. And our last echo image before we ask our panelists what they think about this case is going to be of the descending thoracic aorta, and you can see that we have flow in both the true and false lumen here. So with that, I will stop sharing and Dr. Chatterjee will engage our panelists.
Great. I'd like to welcome our panelists. I'm going to begin with Dr. Malazri. As the surgeon who's consulted on this case, as you approach this case and you're about to talk to your anesthesiologist, what are the initial things that are going through your mind, and what are the things you want to convey to your anesthesiologist?
Thanks, Dr. Chatterjee, Dr. Lingana. Well, for Dr. Hogue and I, we've worked with each other for more than 10 years, so not much has to be said between the two of us, but it is important for the timeout before the operation and also for the junior staff, junior attendings that are going through. There's three things I think that are important. They're not really pertinent here because this looks like a fairly straightforward type aortic dissection, but the first thing is what sort of arterial lines we're going to need. One thing that we're extremely concerned about for type A dissections is not only the malperfusion that exists before the operation, but malperfusion that we can actually create by going on cardiopulmonary bypass. So it is a dynamic situation. Where we put the arterial lines are important. The second thing is during induction, if the patient has a pericardial effusion and tamponade, they can code very quickly just during induction. So it's important to know that everyone knows what the plan is if there is tamponade already before induction. The last thing is nobody should get an incision before the TEE is obtained. So we have to double confirm that it is a type A aortic dissection. This is important because we also have a program where we take patients directly from the ambulance bay to the operating room. We call it the code aorta. We sort of skip the emergency room, ICU, go straight to the operating room. And that mandates quick thinking and double checking.
Great. Let me turn it to Dr. Hogue. So Dr. Hogue, you are, Dr. Malasri has briefed you. This patient now is a little bit hypotensive. Pressures are in the 90s as they're wheeling into the operating room. How do you approach this? How do you tell your trainees? And what's the thought process to an organized approach to make this safe?
Yeah, well, thank you very much. So I think, the first thing is that this is an evolving disease, right? So all the imaging exams are now old and maybe outdated. So this things could have changed. I mean, on the echo that you showed us, there was a little bit of a pericardial effusion. Has that gotten worse? I mean, I'm worried about the coronaries, whether they're having ischemia, whether they have a tamponade, or whether the AI is worse, and or something else going on. So if we don't have a TEE probe, I think that we need to do a point of care ultrasound look at the heart right away. You can do that in induction, because if there's a tamponade, it's a game changer. We got to really address it, because like Chris said, induction could kill the patient. Even positive pressure ventilation, decreased venous return to the heart, pericardial fluid, tamponade could just cause the right ventricle to clamp down, and you can be in big trouble. So I think that we have to realize this is an evolving concept. How we organize, I think, is to take the team, and one person's reviewing the medical record, one person's setting up, and one person's trying to figure out what's going on and what we need to do next. So it is about communication and accepting the fact that this is a rapidly changing environment.
Thank you so much, Dr. Hogue. Just pivoting to our other team, Dr. Ozunian, is there any kind of additional imaging or information you would like to have pre-induction before you accept the patient onto your service, onto your team? Or is there anything in particular you would like to discuss with your anesthesia team prior to induction?
Thanks so much. And I'm sorry, there's this terrible alarm going on in the hospital right now, but it's hopefully gonna stop soon.
We can't hear it at all.
Oh, you can't. Amazing.
No.
Okay, great. So I think Chris and Charles raised some really excellent points. Before getting to the starting the case, we're always communicating back and forth, anesthesia and surgery, to make sure that everyone is on the same page with the condition of the patient. Did they come in were they misdiagnosed? Often they're misdiagnosed as an MI, or they're on apixaban, they've been given ticagrelor, this sort of thing. What are we going to do for monitoring? What's our plan for protecting the organs, the heart, the brain, and the distal organs? How are we going to manage that? And then what's the extent of the operation that we're planning? And that plan may change, but are we doing something, more extensive in the root, more extensive in the arch? Is there malperfusion? And Chris and Charles both brought up, tamponade and coronary ischemia are the two sort of big killers before we get started, I would say. And then distal malperfusion is the other, main reason why we can run into trouble with these cases. So that's sort of where we're at leading up to the case. Marcus, did I miss anything? You're muted.
Thank you. I think everyone's highlighted the main points, which is essentially, I trust your judgment. We've worked together a lot. And the question that I have first and foremost is, how worried are you about this patient? Because it really kind of sets the tone for the rest of the OR, appreciating how fast we have to move, and whether we have time for optimization or we just have to really scoop and run. So as you know, sometimes we do have something similar like a code aorta where we might go straight into the OR. Most of the times we'll touch base in CVICU for, standard blood work investigations, access, and try to optimize as best we can while the OR sets up. But all that communication and appreciating the evolving nature, I think, are the main two things.
Awesome. Thank you so much. Just to, Dr. Azunian brought it up, Dr. Malazri, how would it change your management if the patient did take their dose of apixaban that morning, given our same situation, we just changed it a little bit? Because, we often are presented with that challenge.
Yeah, well, certainly it's not a reason to delay the central aortic operation. And we see a lot of these, not just the apixaban, but just flat out anticoagulation. We have to have a plan for how to stop bleeding after the operation. I'm not so concerned about reversing it before the incision. I'm more concerned about reversing it after we come off pump and trying to dry up.
Next, Dr. Azunian, you brought up malperfusion. So I'd like to get, your approach on the patient who presents with a neurologic deficit, and then also how you approach that, isolated hemiplegia versus someone presents in a coma in terms of additional imaging. How do you approach neurologic malperfusion?
Thanks so much. This is a tough situation, and I don't think there's perfect answers for, how to deal with this. But we do know that people who present with clinical cerebrovascular malperfusion, they still do better with surgery than without surgery. So that's the sort of underlying premise, to all patients. We don't turn down patients for stroke or hemiplegia or even coma. Of course, their neurological outcomes they're at higher risk for having a poor outcome than someone coming in, walking and talking. We do, if we have time and they're, somewhere else, or we have a little bit of time and there's not tamponade or they're not in extremis, we may scan the brain just to see exactly where the level of the, if something reconstitutes, is there complete total occlusion of like the internal carotid, for example, and up into the brain. That can be very bad. And so we may get some additional cerebrovascular imaging, but we don't turn people down for that reason. And we often do have to do a more extensive operation in the arch in that situation, depending on what the anatomy actually looks like, where the tear is, and so on. Chris, do you do something different?
Yeah, I think it's important to differentiate between cerebral ischemia and cerebral infarction. Just flat out, the patient had a stroke. So I think imaging preoperative is really important because there is some things that we can do in the operating room that make the patient better. There are things that we can do to make it worse. So for instance, if the patient has got a large hemispheric stroke that's already done, no reperfusion can help. We're going to make it doubly bad, meaning that we're going to cause ischemia because likelihood we're going to do circulatory arrest for the case. And then our operation will actually reperfuse the brain and expose the brain to reperfusion injury. So in these cases, we involve our neurologists, our neurosurgeons, interventional radiologists, and say if they don't think that reperfusion is going to help this patient, like it's a done deal, like the cerebral infarction is already done, then these patients may not be salvageable.
Got it.
Thank you so much for that. Let's get a little bit closer to induction. So Dr. Hogue, I was just hoping, we have a lot of trainees here and we have people who don't do aortic dissections regularly. Suppose there was echocardiography, you did your POCUS, there were signs of impending tamponade. How would you go about inducing this patient? Who would you want in the room? If you could just walk us through kind of how you take care of this sick individual.
Yeah, that's exactly what we're worried about. The pressure's going down, the heart rate's up, and the reflexly maintaining the blood pressure by just ramping up the sympathetic nervous system. So when you lock the sympathetic nervous system with anesthetic drugs, you're going to take away that, and they're going to collapse, right? Positive pressure, ventilation, etc. And then on top of that, whatever drugs you might use. So I think in this situation, I want Kristen's team there, and preferably I want the patient draped, and a plan if the patient tamponades what we're going to do. And so very, very gingerly, I would probably give a drug. I'd probably use etomidate and whatever, you could use ketamine, but ketamine supported the circulation only works if you still have a sympathetic nervous system. If you depleted all your catecholamines, you could get just as much hypotension as you can with anything else, right? So I think that we certainly we'd be ready to go. It would be like a C-section, I always say. Everybody's draped, ready to make the incision when you induce anesthesia. And then we would induce, obviously, and then we would also have like some norepinephrine in line or even some epinephrine in line so that we could follow up with any problem. And I would have Chris start his incision as I was putting in the the tracheo tube. Pop the echo in. We could worry about lines. We'd probably have some lines already, but we could worry about that once we get the chest open and the tamponade under control. So this is the time you got to communicate and stay incredibly calm.
Oh, thank you for that. Dr. Salvatore, anything to add or anything that you guys would do a little bit differently at your center?
No, I think the most important thing is, as Dr. Hogue said, being prepped and draped at the time of induction, appreciating that you can be fooled very easily, meaning that, you might see a patient say, oh, they're relatively stable. We could probably do things as we would for routine cardiac surgery. And I think that catches people off guard many times. You have to have a really high index of suspicion for the potential for a collapse on induction, and have a discussion with your surgeon up front saying, everybody in the room, patient prepped and draped before we do anything. I think, a lot of the classic tamponade teaching stands here. So what medications you use depends on what you're most comfortable with and what you're most familiar with. I don't think there's one recipe that works for everyone. But at the same time, it's just keeping as cardio stable as possible.
Sticking with the theme of malperfusion, for Dr. Malasry, visceral malperfusion, lactate 6, abdominal distension, clearly on imaging, there's some evidence of malperfusion. There's a debate on, do you do the chest first? Do you do the abdomen first? How do you approach visceral malperfusion?
Yeah, this one is also a tough one. Again, the ischemia versus infarction problem. If it's just ischemia, we will take the patient directly for central aortic repair. We think that's the best way to take care of two problems, the risk of rupture of the ascending aorta as well as the malperfusion. However, there is straight out gut infarction, and sometimes it's tough to tell. It really is tough to tell. Then it may be reasonable to offer a delayed central aortic repair in favor of reperfusion of the bowels first. So in that case, hybrid OR, I think, is a great place to go. Our vascular surgeons are involved in all of our type A aortic dissections, and you can pivot pretty quickly to an endovascular case with a goal of reperfusing the bowels.
Dr. Ozonian, in Toronto, anything different as to how you'd approach it in Toronto?
I think the key thing is what Chris mentioned, is to distinguish between malperfusion and then malperfusion syndrome, where the organs are already like infarcting and dying, the visceral organs, and visceral organ infarction will, kill you. So it's rare. We're in general, we favor central aortic operation first for most patients, and then with a low threshold to image and deal with distal malperfusion afterwards. And we may be more extensive in the arch in the malperfusion cases, or do, some different technical things. But for patients who come with true bowel infarction, very high lactate, abdominal distension, etc., we do what Chris described. We treat the distal malperfusion first, and it's usually endovascular. It's either a covered, short TVAR in the descending aorta and then dissection stents all the way down, or what Michigan does, like cheese wire fenestration, endovascular fenestration of the septum, so that both so everything is reperfused distally, both lumens are reperfused. We have favored the former, but vascular surgery is involved, and then we would reassess, let the bowel infarction, the liver problems die down, and then do a central operation. Of course, you cannot do this if there's tamponade or severe AI and, you know, a reason, coronary ischemia and so on. But those patients are often critically unwell.
Great. Dr. Salvatore, from an anesthetic optimization and management in these cases with visceral malperfusion where you expect a rough course, how do you prepare for that, or what are you watching out for?
I mean, there's very little that you can do to prepare or optimize in preparation for surgery. Really, like the key is this is a surgical problem and it needs a surgical solution. All you can do is try to avoid prolonged hypotension and hypovolemia. Those are really the only two things in your power. Try to maintain perfusion pressure as best you can, which can be difficult depending on the exact constellation that the patient is presenting with. But this patient needs surgery is ASAP, and moving quickly is probably the best way to preserve any malperfused organs.
Great.
I think this is where we put arterial lines is important. I think, Chuck, we like to have bilateral radial A lines, and then the surgeon can place femoral arterial lines as a third monitoring line. I wonder what everyone else is doing across the country.
We typically always we try to have if the arms are perfused, let's say before surgery, they have both are perfused, we would typically have a right radial, and then the surgeon puts in a femoral line to monitor, you know, distal perfusion, and the right-sided A line to monitor antegrade cerebral perfusion during the CERCREST portion. That's typically what we do. But if there's some malperfusion, we actually favor monitoring that malperfused arm or leg also, so that you can have an early signal for when is it resolved at the end of your procedure. And I think for all cases of malperfusion, a very important message to the trainees on is that we should have a very, very low threshold to image these patients very early after surgery. Sometimes there's a fear of, oh, the kidneys are going to get hurt. We don't want to give them dye, go on a road trip and so on. But if there's a sense that there might be bowel, kidney, you know, distal malperfusion, we should go do the CT scanner and assess this.
No, I
One
think
thing
that's
I'll
great.
add,
Oh, go
one
ahead.
thing I'll add just about trying to understand from an anesthesiologist perspective, the surgical approach will put you in good stead and is always advantageous. So for instance, we have different aortic surgeons that use different anterograde cerebral perfusion strategies, appreciating that some of which will make you lose your arterial line, some of which will allow you to continue to monitor. So appreciating the technique that's being used on the surgical side is also beneficial for any anesthesiologist. And I always recommend my trainees are involved in those discussions so they know what's happening in real time.
For the sake of to benefit, let me ask Dr. Malasry and then Dr. Uzunian, tell me what the default classic dissection repair is in your hands in Chicago and in Toronto in terms of cannulation strategy, degree of hypothermia, cerebral perfusion, just sort of a higher level view, you know, what's sort of your default approach?
Yeah, this is a 10 surgeons, 10 answers type thing here. So I'll tell you what we'll do. I think our default operation is a right axillary cannulation. We're going to do hypothermic circular arrest with antegrade cerebral perfusion, go to moderate hypothermia, so 26 degrees, and plan on doing a valve resuspension, total ascending, open distal anastomosis.
Great.
Well, it's actually, I would say our approach is quite similar to what Chris describes. In the classic patient with a DeBakey type 1 dissection without a specific root indication, you know, a large aneurysm or a tear in the root, or a specific arch indication, you know, big aneurysm or a tear in the arch, then we would do, I prefer right axillary cannulation. Central aortic cannulation has gained in popularity, I would say. It needs, Seldinger needle and TEE guidance to make sure you're in the true lumen. I've preferred to just stick with the tried and true graft on the axillary. And then moderate hypothermia, I do go around 26 degrees, even for a hemiarch in a type A, because you never know once you open, will you have to do a zone 2 or a more, more intensive operation distally. And I typically clamp the aorta and work on the root if there's a lot of work to do on the root, if I know I'm going to have to do a valve sparing or a root replacement. Otherwise, particularly for patients with IMH that have this like hematoma, thick, toothpaste hematoma in the false lumen, in those where it's resuspension of the valve and thick hematoma, circ rest first, do your distal, and then do resuspension of the valve and the proximal at the sinotubular junction.
Great.
I'm just curious, Dr. Hogue and Dr. Salvatore, there is, I guess, a paucity of evidence on what medications and what we can do for cerebral protection other than perfuse the brain surgically. I'm curious at your centers what you guys do for in terms of anesthesia aspect of cerebral protection.
Well, I think that the primary thing is the temperature, right? Is cooling the brain. And I always worry about unknown cerebrovascular disease. We did a study where we had like 150 MRIs, and the frequency of white matter hyperintensity was like 30%. So these are people who have small vessel disease, and I worry about the cold temperatures getting there and perfusing the whole brain. But that's the best we have. We've been down this rabbit hole of trying to find the secret magic bullet to protect the brain with drugs, and nothing's really worked. I think that the pathophysiology of brain injury is just so complex that one drug won't work. So it's temperature and everything we can do to help get the temperature down, monitor the patient, the NIRS, look at the EEG. And then before circ arrest, we do have a little bit of a protocol for better or worse, where we give some steroids, a gram, and we use magnesium, and that's mostly based on animal data and pharmacological reasons. And then we have a protocol where we give some divided doses of mannitol at reperfusion, hopefully do some free radical scavenging. So whether all of that works, I don't know, but it's our routine, and it's based on pretty sound pharmacologic and experimental evidence. But I think it's the temperature, making sure you can get the brain cold, is the best thing we can do.
Yeah. Dr. Salvatore, anything different that you guys do in Toronto?
Yeah, so we generally don't do much in terms of pharmacotherapy for cerebral protection. Classically, the textbooks describe things like steroids, as Dr. Hogan said, as well as barbiturate or thiopental comas, try to burst suppress patients. We don't tend to do anything like that in Toronto. I think NIRS monitoring, looking for any great gross discrepancies in the left and right side, because there are some maneuvers we can do to try to salvage perfusion in those contexts. And then temperatures, Dr. Hogue has already said. We don't tend to do things like external ice packs or anything like that. We don't think the evidence supports it. So it's essentially just good surgical management is what we keep.
Great. Dr. Malazri, taking a question from the Q&A. There is, you both mentioned antegrade axillary cannulation. What is the role of femoral arterial cannulation, or along those lines, even central aortic cannulation? So anytime, when would those be appropriate in your practice?
I think femoral cannulation still has a good role for type aortic dissections. Again, we were talking about the emergencies before. Sometimes you're forced to cannulate very, very quickly. In femoral arterial cannulation, you can be very quick. So I think that's a good option for you. People always ask, well, do you do the ischemic leg or the non-ischemic leg? I don't think it matters. We'll perfuse both legs. So we go after the non-ischemic leg. We'll do a small cannula in the contralateral leg that's ischemic. sort of like the antegrade perfusion cannulas that our friends in heart failure use. They call it the APC or the DPC. So I think cannulating both sides is just totally fine. For central aortic cannulation, I think Dr. Lingana has more experience with this. I'll just make one comment. That's also growing in use in both the United States and Europe. Dr. Lingana's institution, I think, is one of the pioneers for this, but it is not your standard central cannulation. This is one where you have to be in tune with the echocardiography. You have to get that cannula into the true lumen, and you're not doing it just by yourself as a surgeon. You need your anesthesiologist to be guiding you in order to get the needle and the wire in the right spot. The cannula tip has to be in the true lumen, or else you're going to make malperfusion.
Great. Dr. Razonian, I'm going to change the patient a little bit from a 77-year-old.
Just comment
Sure.
very quickly. I agree with what Chris has said. I think femoral cannulation still has a role in really like dire. If you're doing CPR on the patient and they're in the OR and you're going ahead with an operation, that's the fastest, way to get them on pump. But once you're done the circ rest portion, then we would switch to antegrade flow, through a sidearm of that graft, just to make a point of that. Once you're rewarming and you have reestablished, your distal is done, then go back to antegrade flow at the end of that. And I would say, as he said, you really need TEE guidance to do this central aortic cannulation and dissection. And, there's a risk that this thing ruptures, but, usually more and more places are doing it and are happy to do it. Yeah.
So what I was, the question so let's say this patient's not 77, but is a 40-year-old man with Marfan syndrome. How does that influence, how do you take that into account when you decide what to do for the valve, what to do for the arch? How does hereditary conditions influence your decision-making?
Thank you. Great question. Sometimes we don't know that they have syndromic aortopathy. Their age for sure can give it a little bit away. I think one piece of data that we know is true is if you leave the root alone in a type A dissection in patients with Marfan syndrome. There's a circulation paper that reports this. Their risk of coming back for a root operation is nearly 100% in a short amount of time. And so it does change for sure how aggressive we are at the root. If their valve is good and they're a good patient and they're not dying of distal malperfusion, we would consider a valve-sparing root. If all the stars aligned and the surgeon's comfortable and the valve is perfect and the patient is good, that would be our preferred method. But we would for sure replace the root, and essentially anyone we know has Marfan syndrome would get a root replacement. And then distally, I don't particularly, I don't do a total arch just because they have Marfan syndrome. I would rather get a good, valve-sparing root operation done and do what's needed in the arch. If they need a total arch, then we would. But often these very young patients have actually a small arch, and so they're not very big, and it actually makes doing the total arch more technically challenging, and unless it's necessary, we would not. Yeah.
Great. Dr. Malaisri, anything to add?
Yeah, this is where the surgical plan is really important, because I want to be able to communicate to our anesthesiologist how long this case is going to be, because this could be a long case, and maybe we should get some dinner before we start this case. And a breakfast morning. So the young patient with a Marfan syndrome, in my view, has the most to gain and least to lose with an extended operation. What I mean by that is they have a long lifespan ahead of them. So an extended aortic operation may be beneficial to minimize any future operations. But because they're so young, they may be able to tolerate a longer procedure. You certainly wouldn't be looking at a valve sparing total arch frozen elephant trunk in a 75-year-old, but you've got a young Marfan patient, definitely the root has to be replaced. But I think it's reasonable to consider an extended operation for a young patient who can tolerate it. So valve sparing aortic root replacement, arch frozen elephant trunk. It'll be a long case for that patient, but they've got the most to gain.
Yeah, it's a great segue that you mentioned the frozen elephant trunk. Can you guys talk about your surgical decision making on when you would look to do that? And then I'll pivot to our anesthesia colleagues and ask them how that might change our anesthetic management, either intraoperatively or concerns postoperatively with that.
I think that the data is not completely clear on exactly when to do a frozen elephant trunk. We actually have a randomized trial underway now in Canada. We've only randomized 10 people, so it's a hard trial to randomize in, randomizing patients with DeBakey type 1s up to the age of 80 to hemi-arch versus total arch frozen elephant trunk. Typically outside the trial, we would do it if there's a tear in the arch, if it's any significant arch pathology, or there's a tear in the descending, let's say it's a retrograde type A dissection with a tear in the descending. Young patients, as Chris said, they have more to gain from a more aggressive, extended arch operation. And these would be all considerations, and also how much you have to do in the root. Yeah. Chris, what about you?
Yeah, I think the same. And I think that for Americans, we're a little bit behind the rest of the world. Frozen elephant trunks were pioneered both in Europe and in Asia more than about 2 decades ago. And frozen elephant trunk usage in Asia for sure is way ahead of the United States. And they're able to demonstrate pretty good outcomes with that. Maybe less risk of downstream aortic surgery. There is a risk with it. The Asians are showing maybe a little bit higher risk of stroke, but that is to be expected with extended arch procedure. So we're not quite sure where we stand with frozen elephant trunks and total arch procedure for type A aortic section. But in our practice, I'm looking for a reason to do that. I mean, if there's a tear, we could see the tears now on the CT scans preoperatively. So that really helps us. There's a tear in the arch. And if there's malperfusion, I'm more apt to offer an arch frozen elephant trunk.
Any technical pointers, Dr. Malaysia, Dr. Uzonian, in terms of how to avoid a disaster with a frozen elephant trunk? So, for those who don't do as many, things to make sure you avoid.
Keep it short. Do not put the only patients who have paraplegia after acute type A, if you didn't come in with paraplegia, the only patient who's going to get paraplegia is someone with a frozen elephant trunk. So we never put longer than a 10-centimeter stent. We tend to facilitate and do a zone 2 anastomosis and deal with the innominate and carotid and do something. If the subclavian is favorable, sure, do zone 3 and do the subclavian also. If not, you can just do a separate axillary incision and tunnel a graft out there. There's other things you can do to simplify. You don't want 1 hour circ rest time just to do a frozen elephant trunk. So I think doing them in the elective setting before in the emergency setting is also very important. You need a wire and it has to be TE guided and into the true lumen. Putting it in the false lumen's the other disaster apart from paraplegia that can happen.
And then Dr. Hoag, how does the frozen elephant trunk change what you're doing on the other side of the drapes at all?
Well, yes and no. It increases the worry, right? I mean, not much we could do I mean, we worry about whether it's going to affect the cerebral circulation or on the distal side. But if we're worried now about spinal cord ischemia and we've got this complex case, I might be thinking is there something I could do to facilitate getting this patient awake a little bit quicker, and maybe you can do a neurologic exam. And that would be probably, I use a lot of Precedex, dexmedetomidine, and maybe we can get that going where we could keep him sedated afterwards, but at least maybe he could participate with an exam. Because if he does have paralysis, then we have to start talking about putting a spinal drain in and somebody who's coagulopathic and all that consideration. So I think it does make it a little more complex, but let's go for it. You know, let's do the best for the patient.
Yeah. Dr.
Awesome.
Salvatore, Dr. Hogue just brought up coagulopathy. That's certainly bleeding is a major problem in these cases. First, from an anesthesia standpoint, in terms of perioperative management, and then I'll follow up with the surgeons from an intraop standpoint. What are the best anti-bleeding strategies or management strategies to try to reduce transfusions in a case like this?
I got to be honest, there's not really much in terms of reducing transfusions. I think the key is really just being prepared as best as possible with ROTEM or point of care guided coagulation testing, appreciating that it evolves constantly. Lab work is going to be less reliable because the lab work that you sent 15 minutes ago doesn't stand within 5 minutes, essentially. So we're heavily dependent on ROTEM. I think appreciating the context of the patient's coagulation status. As Morale said, a lot of patients come in, they may have received antiplatelet agents, they may have been on an anticoagulant that is reversible or not. So I think making sure that all that's taken care of. You know, we use a lot of tranexamic acid as an antifibrinolytic, and then ROTEM guided transfusion. But I think, you know, just being prepared and appreciating that you have to be very aggressive when it comes to hemostasis in these patients. This isn't the type of patient that you could give one product at a time and then wait and see what happens. I think it's all hands on deck. Throw everything that you have in a guided way at the problem, and then try to get hemostasis as quickly as possible. And I think that's probably your best bet for reducing red blood cell transfusion at the end.
I don't know what Marcus is talking about. I've never had a bleeding patient ever. No, I think the point was really well taken. What really kills us, and first of all, nothing is a substitute for proline deficiency. So, you know, proline is your best hemostatic agent. But until sometimes it really is a true coagulopathy where, you know, all the needle holes are going. And so in that instance, until the coagulopathy is resolved, it's really hard to even identify surgical bleeding. And so I would say what is really, you know, painful and I think counterproductive is to do the, you know, one like thing at a time in that situation. If you have true significant coagulopathy, fix what's wrong. If you know it's platelets and they've had ticagrelor or something, you know, don't give one, you know, just kind of keep it rolling and then once it dies down, it just makes it easier to control if there's a surgical problem also.
You know, one of the things
we don't bleed in Toronto. Yeah.
Oh yeah, well, because they're cold. Maybe I don't know, whatever. I don't know. Basic concern. No, you know, one of the things I think has changed most recently in our practice is that we send the ROTEM when they're warming. You know, we have to get up to probably at least 30. You know, platelets will get sequestered in the spleen if you're cold, so it might not be accurate. But we get a ROTEM while the patient's warming, so we kind of have an idea what's underneath it, and it's very helpful to direct. You know, if your MA is small, you know, what's the fibrinogen and things like that, get cryo up right away, or even fibrinogen concentrate, but try to be proactive. And then based on that, we probably start our first line of transfusion and probably not check until we get some products in. Check again after we get a couple rounds of platelets and FFP if we really got a big problem.
How often, how about prothrombin concentrated complex, activated 7, other agents, any that you prefer, any that you try to avoid?
I think the PCCs have been really remarkable because you get a lot of bang for your buck, right? Not a big volume, and you get, you know, good factors 2, 7, 9, and 10 with the you know, getting into those other more activated factors like Nova 7, but also the FIBA, where you're getting into kind of a dangerous area there because you're giving activated factors, right? They're ready to start clotting, so they do have a role if you have really uncontrollable bleeding and you've gone down everything you can give. I think there's a role, but I think when you cross that line, you have to be in a situation where you really have a bad coagulopathy and nothing else is working. In my view, Marcus, I don't know what your thoughts are.
Yeah, I think I'm as scared of factor 7 as I am, you know, seeing it as a good tool, meaning that every time I've given it, I'm kind of on the edge of my seat looking for thrombotic complications afterwards. and we have had them. Truthfully, would you have made it out of the OR without it? Is the question. But even once you do, and the factor VII does its thing, then you're looking for renal failure afterwards. You're looking for any probable thrombotic events that you've precipitated potentially with the use of this very powerful and very unpredictable hemostatic agent.
And sometimes you get by with a little bit lower dose than what you would think. You don't have to give the full dose. You could just like give a quarter of it and see if you get a response. I think the question would be is if this patient was taking a 10A inhibitor, and would you use one of the new index antacids? I think we all learned that lesson that you shouldn't be giving those in cardiac surgical patient because it inactivates heparin, it interferes with ACT, and you're really going to cause a problem.
Right.
And the question would be if they got it before they came to surgery for some reason in the ER, then you got a real something to consider what you're going to do.
For Chris and Maral, you're both internationally renowned aortic surgeons who do a lot of aortic surgery. But what about the surgeon who does 1 or 2 dissections a year? What are your biggest take-home points so that at the end of the day, the most important thing is that they end up with a live patient. So in terms of your practical advice, what would be your take-home messages?
Well, I think that is the average surgeon in the United States, meaning 1 to 5 acute type A's per year. My advice is to keep it simple, not just for yourself, but your entire team. Because if you haven't seen a lot of acute type aortic sections, well, neither has your anesthesiologist, neither have your nurses, and neither have your perfusionists. So try to keep it as simple as possible and try to shy away from extended aortic resections. And know when to refer out as well. There is some time to get the patient to another center if it is a complex type A aortic dissection.
Yeah, great points, Chris. I think the key thing is to do what's necessary to try to get the patient out alive. And if you're only doing, a handful of these or less a year, which most people and centers are, you can leave the root or the arch for, live to fight another day, is the main take-home message. Keep the operation simple, but you must resolve coronary malperfusion, low threshold to graft if there's an RCA occlusion, for example, and you cannot leave the room with severe AI. And so you have to fix the AI and the coronary ischemia and then do as much as what's needed proximally, and then, figure out the rest another time. And we do we do get referrals from other centers with cardiac surgery if it looks like there's, more, sometimes it's an infrastructure issue. They don't have vascular and IR, and someone comes in with distal malperfusion. And there are some data out of California and other places that actually referring to an aortic center, of course, there's a risk benefit of the waiting to get someone to an aortic center, but in these very complex dissections, it may be worthwhile to refer out.
Maral, that's a great transition to a question that's in the chat about transfers. So I'm going to pose it to both of you. How do you decide what transfer to not accept? How do you decide who not to offer surgery to? What goes through your thought process in terms of that? For example, is there an age threshold at which you'd say no? So how do you juggle those?
Yeah, these are great questions. I see they came from Kim De La Cruz. Hi, Kim. There is, IRAD showed that there's actually an age at which the medical therapy and surgical therapy survival curves cross, like somewhere in the mid 80s. And so although we do type A repair like into the we have done even into the late 80s, once you pass kind of 87, 88 years old, like your ability to actually recuperate from this type of operation really goes down. I have turned people down for age, comorbidity. You know, if you're like late 80s and you have some cancer, the pathology is really bad. And in those instances, sometimes I do decline them even by phone, but then I will have a conversation if they're very far away. We try to save the family the pain of a transfer if we're going to, you know, I had one a week ago, it was 90 years old, and the arch was totally ruptured, and already in extremis, the patient, they, you know, high dose pressors, was going to need a very extensive repair and was very frail and wasn't really walking before the event. So I turned her down, but I make sure that I have a conversation with the family, and I spend actually quite a bit of time on the phone explaining to them like what would be involved with an operation and the risks of it and why we think we would not be able to help their family member. And I think they deserve at least that conversation if you're going to decline the transfer.
Yep. Dr. Malasri?
Yeah, I think we'll take a look at pretty much every patient. The one patient I really don't like to transfer is the patient who was already DNR. There's no reason for them to transfer to us, for us to pursue the DNR order. But we'd like to take a look at all of these patients because there's other options, not just central aortic repair, but endovascular options. So we heard about endovascular options for the type B aortic dissections. There's investigational devices for endovascular options for the ascending aorta. So there's dedicated stent grafts to cover the primary intimal tear in the ascending aorta. That could be a therapy for high-risk patients with type A aortic dissections.
And then a question that came through the chat that I'm going to pivot on a little bit is how would you manage the dissection if it occurred as a result of a TAVR? So I'm first going to ask our anesthesia colleagues, in terms of your typical TAVR, are you set up to prepare to manage a dissection, or is your access going to vastly different and anesthetic management going to vastly different between TAVR and dissection? And I think I know the answer, but
I'll let Marcus go first.
Yeah, I would say incredibly different. So, you know, we have a very high suspicion, or, you know, we're vigilant, not I wouldn't say high level suspicion, but we're vigilant every time we do TAVRs for any possible complications. We do have obviously femoral access, which we would temporize in an extreme situation that had an acute dissection that was, hopefully not uncontrolled and unstable, but rather just something that we recognize and needs to be addressed. We identify whether the patient is a pump candidate or a surgical candidate up front, and that's all discussed with all members of the team. But we would have to pivot quite quickly in those situations because we're completely, it's two different anesthetics entirely.
Yeah, you know, I think it's interesting to watch this whole thing unfold. And I don't want to, I hate to say have we become a little bit too cavalier. You know, we're increasingly doing these with sedation only, and there's places that are doing it without any anesthesia support. And then if you have something like this happen, you're going into the room de novo, not knowing anything. So I do think that you can never take any of the TAVRs lightly. You got to think what bad could happen today, and have in the back of your mind so you're ready, at least mentally. But most of the time, fortunately, they go well. But I do think you have to take every one of these seriously because they could be old, frail patients, right?
yeah, no, thank you for that. And I think we're running close to the top of the hour. So I think our last question, I think I'll pose the same question to Dr. Malasri and Dr. Ozuni, and how is your management going to change if this comes as a result, a complication of a TAVR?
Go ahead, Chris.
Yeah, fortunately, these complications are very rare. So acute type aortic dissections from the cath lab, whether that be TAVI or PCI, are very rare. And they're typically not intubated. So the patient will probably tell you that there's a problem. Fortunately, a lot of these dissections can be managed non-operatively if they are isolated to the root only. Only if like the horse is out of the barn type thing. If the dissection does go all the way around, then we're treating this like a standard type A aortic dissection. But fortunately, they are uncommon.
Chris, tomorrow afternoon, second case Friday, you're cannulating for a cabbage and you encounter an iatrogenic dissection. So your Friday afternoon is ruined. But how do you manage, or what's your advice on how to manage iatrogenic, at the time of surgery, aortic dissection?
Yeah, it depends on it depends on how we cause the iatrogenic dissection, and usually it's from the aortic cannulation, and it all depends on whether or not you've seen it before or after you go on pump. If you've seen it before you go on pump, then simply relocate that cannula. You got to seriously consider doing an ascending replacement at that time. After you go on pump, boy, it's a really tough call at that point. If you're able to still perfuse the true lumen, then pursue the operation. Now it's two operations. You got to take care of the primary problem while you're there in the first place. And now you're definitely going to have to replace the ascending aorta.
Yeah. In my experience of seeing this rarely, but if you've gone on and you're still warm, you could always come off, right, and let the perfusion pressure close it while you plan on what you're going to do next, and so you don't have the panic and risk malperfusion. And I've seen that a couple times, and I was glad it happened, actually. But if you're getting cold already, you're sort of committed.
Yeah, fortunately these are rare, but they do ruin the Friday afternoon. That's for sure. But it depends on when it happened, how it happened, the extent of it. Is it just, is the flap going all the way around? Is the aorta like rupturing in front of your face? You're almost always, if it's a bad one, you're going to have to deal with it. And it may mean resiting the arterial cannula. It may mean adding additional monitoring that anesthesia can use. And in the CABG situation, it's quite bad, because once you start adding, multiple grafts to replacing the ascending aorta, and there's a heart protection issue as well. You don't know if the lema's been affected from the left subclave. You don't know what the perfusion of the lema is going to be, and so on. It's pretty bad. What Chris mentioned though from the cath lab, I do want to mention that sometimes these like very focal root or dissections caused by like an ostial RCA, like engaging the RCA, and they cause a dissection, put a covered stent. Those can often be treated medically, and we just monitor those and keep scanning them, and then and unless they're like rapidly deteriorating, you can most often manage those medically. Yeah.
Great. As sort of a final, maybe with a little bit of a crystal ball as our last question, what has you excited in this field, sort of, in the next 10 years, maybe surgically, maybe endovascular, from a medical management? What do you think in the next 10 years with respect to dissection? What has you excited for potential therapy? Dr. Zoni, I'm going to start with you, and we'll go around the panel.
Sure. Thanks so much. And this has been such a fun webinar. It's great to hear like different practices and what people are thinking about. I think aortic surgery, if you look at it 10 years from now, 10 years previously to now, it really has changed so much. And this is partly why it's such a exciting field. There are very few trials in aortic surgery, either elective or emergency surgery. So the quality of the data is always quite variable. I do think we will see more data growing and more, better options for our patients to have durable long-term operations, both at the root and in the distal aorta. And type A dissection mortality really, even in IRAD, has not gone down as far as we want to go. And whether the answer to that is, centralization, different types of operations, it'll be interesting to see, but I think it will look very different 10 years from now.
Dr. Malasri?
Yeah, what I look forward to with acute type aortic dissections is not having to do any more acute type aortic dissections. I think we're going to have better ways to predict who's at risk for this terrible catastrophe. Right now, we're relying on mostly just size diameters, and those are just patients we actually know about. So I think better imaging, predicting which small aneurysms are going to dissect. Hopefully, artificial intelligence can use a whole bunch of baseline characteristics and tell us which patient is at risk for acute type A dissection, because Fixing a aortic aneurysm electively is a very safe operation. Fixing an acute type aortic dissection still runs in the teens, maybe 20% operative risk. So we'd like to get it electively rather than as an emergency.
Great. Dr. Hogue.
It just getting better. I've been at this for a couple of decades now, and cardiac anesthesia now is more fun than it's ever been. All the stuff that we could do, all the procedures. I think monitoring will continue to improve. And I think that we're really at the precipice of some really, I think, breakthrough with automatic AI, predictive analytics. I think the monitoring of the brain has got to improve, and it will improve. Better ways that we can look at the protection. One of the challenges we have right now is the shortage of personnel. And, I think 57% of anesthesiologists in the US are over 55. So I think that one of the things we're going to have is we have to continue to train people and figure out ways that we could do this probably from a manpower perspective. But I totally anticipate this is only going to get more fun and better.
Great. Dr. Salvatore, last words.
Yeah, I would just say for me, any mechanisms or means that we have for cerebral protection, renal protection, organ protection in general, for those at risk of malperfusion and consequences and sequelae of this big operation. And then, as Dr. Nasri said, the possibility of endovascular options for those that would currently being turned down for surgery might extend our therapeutic window to a greater number of patients.
Awesome. Thank you so much. And with that comment, we will wrap it up for tonight. Thank you so much to our speakers from both the University of Toronto and Northwestern for sharing their expertise with us. Thank you to my co-moderators, Dr. Chatterjee and Dr. Arora. And a big thank you to the behind-the-scenes teams from both STS and SCA for making this idea of ours a reality. We hope to see you all again soon for another upcoming collaborative session. And now we'll have a few words about upcoming events from both STS and SCA.
Thank you so much, Dr. Lingana. On behalf of the STS and SCA, thank you to our SCA and STS moderators and panelists for your participation and insight. The next installment of the STS-SCA webinar series is coming in November, so stay tuned for that. If you're not one already, we invite you to become a member of STS. You'll enjoy a variety of discounts, benefits, and opportunities to help you grow professionally. Learn more at sts.org/membership or scan the QR code on your screen. Registration will open soon for STS 2026. We hope to see you in New Orleans. Find more information on the calendar of events at sts.org or again, the QR code on your screen. In addition, be sure to check out all these great coming SCA events in 2026. Lastly, as Dr. Arora pointed out, the inaugural Cleveland Aortic Symposium, endorsed by STS, will take place next week on September 5th and 6th. Again, thank you so much for your time and attention. Have a great weekend, everybody. Take care. Bye-bye.